Despite the high success rate of modern macular hole surgery, the management of large recurrent or persistent macular holes remains challenging. We present 3 such challenging cases. Case 1, a 59-year-old lady with right eye 660 vision and macular hole more than 900 microns underwent 25 gauge vitrectomy. I-OCT confirmed large, relatively flat macular hole. After staining with BBG dye, inverted ILM flaps were fashioned, trimmed and apposed onto the hole with closed 25 gauge forceps. However, I-OCT showed hole not covered by flaps. A small bubble of PFCL was injected on the macula using soft tip. Under PFCL, the 25 gauge loop was used to gently push the ILM flaps into position. I-OCT confirmed flaps well apposed on the hole. Careful air fluid exchange was done with soft tip placed nasal to the disc, followed by C3F8 gas tamponade. Repeat I-OCT confirmed flaps in position over the hole. Post-operatively, vision improved to 624 right eye and OCT showed closed macular hole with restoration of retinal layers. Case 2, a 50-year-old gentleman with right eye 3/60 vision and large macular hole underwent successful 25 gauge vitrectomy, ILM peeling and C3F8 gas tamponade. However, 4 weeks post-operatively, he had recurrent macular hole. During resurgery, ILM flaps were found dislodged and apposed to retina around the hole. A small bubble of PFCL was injected over the macula. The 25 gauge loop was used under PFCL to gently reposition the dislodged ILM flaps over the hole. I-OCT confirmed flaps well apposed on the hole. Careful air fluid exchange followed by C3F8 gas tamponade was done. 4 weeks post-resurgery, vision improved to 618 right eye and OCT showed closed macular hole with normalized foveal contour with restoration of retinal layers. Case 3, 68-year-old gentleman with history of macular hole surgery elsewhere presented with giant refractory macular hole in left eye, 660 vision and largest basal diameter of 2460 microns. 25 gauge MIVS surgery was done. Nasal and inferior peripheral retina were found to be detached. I-OCT confirmed the magnitude of the crater. Brilliant blue G dye was injected, however no residual ILM could be found. 25 gauge chandelier was fixed at 6 o'clock. PFCL was injected over posterior pole. BBG dye was re-injected but useful ILM could not be mobilized. Diathermy was done to mark area of retinal harvest. Retinal autograft was fashioned bimanually using 25 gauge forceps and scissors. Graft was carefully transferred under PFCL and placed on the macular hole using two 25 gauge forceps. I-OCT confirmed coverage of macular hole. SRF was drained and PFCL aspirated. Endolaser was done around retinotomy and around retinal breaks in detached retina. Localized pocket of SRF in nasal periphery was drained. Silicon oil was injected. Post-operatively, retina was attached. Macular hole was plugged with the retinal autograft and vision improved to 636 parts. In 2010, Dr. Naurocki's group first reported good results with inverted ILM flap for large macular holes. They hypothesized that peeled ILM flaps may provoke gliosis and provide a scaffold for tissue proliferation. Subsequently, they have proposed the underlying mechanism of flap closure after the inverted ILM flap technique. Various modifications of the inverted ILM flap technique utilizing PFCL have also been reported for macular hole and macular hole RD. The posterior counter traction exerted by PFCL facilitates ILM peeling and prevents diffusion of dye. PFCL prevents macular hole enlargement by minimizing traction and also helps in inverting and stabilizing the ILM flap. The PFCL peel technique has been shown to efficiently improve the creation and transplantation of ILM-free flaps in persistent or recurrent macular holes. Owing to its unique design, the nitinol loop has been utilized to create autologous retinal autograft for failed macular holes and macular hole detachments. As per current evidence, it is difficult to determine if one approach is superior to others for large or recurrent macular holes. Based on our experience, we conclude that PFCL-assisted inverted ILM flap technique can be used as primary approach for large chronic and recurrent macular holes. The nitinol loop can be used very efficiently and safely to manipulate the ILM flaps under PFCL. Autologous retinal transplantation can be the last resort when conventional surgery fails and ILM has been exhausted. PFCL acts as an efficient third hand and intra-op OCT is a useful third eye adjunct in achieving successful outcome.